This conference
And
will now be recorded.
okay, so when the department has said that they want certain quality initiative for the services that are provided, and this in some ways is HCBS 2. So, first we went ahead and assured that people were meeting the regulations. But regulations in most cases are like the floor. They're the minimum standard. You got to do at least this to make sure you're in compliance. One of the concerns that a number of the stakeholders had when the rate study methodology was being completed by the department and by their contractor, Burns and Associates, was that what are we doing to make sure that there is quality in the services that were being provided? Because, if you're going to uh, sort of equalize the rates that everybody gets, so if you're like a specific, like a day program provider under these service codes, and they're changing some of those service codes right as we speak. Um, and you're getting the same amount of money. And over here, we have somebody who's doing a good job with, meeting goals and objectives and community integration. And over here, we have somebody who's doing a more traditional day program. They met the minimum standards for home and community based waiver, but they're really not doing sort of state of the art type services. Uh, that they wanted to try to move away from that, so that they put out an expectation. So by 2000 July 2026, the department's goal is to have at least one objective for every service code for a quality objective that people will have to meet in order to get that last 10%. So, everybody's going to get, as a base, everybody's going to get 90% of the established rate under the new system. And then you need to earn that last 10% predicated on meeting standards. And as you were saying a few minutes ago, Leslie, for the first year and a half, the standard will be that you've done what you need to do to have an accurate depiction of your program on the DDS directory, and that will meet the criteria for the first year and a half. Come, like I say, July 2026, then there will be these specific quality indicators for each service code that you'll have to meet. And like I said, the department is saying there'll be at least one, if not more. And they're going to be sort of focusing on 6 areas. And those areas, the first one is experience and satisfaction. And we talk about personalization, individual services to meet individual needs and preferences. So the whole idea of you go in there and it's cookie cutter, and we well, let's say as an example, a day program. Well, everybody's going out in the community to this site. So we're out in the community during the day. We're doing this. Well, you didn't individualize that service. So maybe you can say that you are, you know, integrating clients, getting them out there, but you're really not doing it in a way that meets the needs of that one individual. And also that you want to make sure that you document and have pretty good records to show that the individual themselves were an integral part of making that plan. So it's we say it over and over again. It's hey, it's your plan. It's you being the individual served, but we're all sitting around the table, and in many cases, people are saying, "Well, uh, Mary, you'd really like to do this, right?" And so the is that really Mary making the plan, or is it the staff person, you know, sort of assisting Mary in plan development? Um, and then ensuring that the people whose plan it is have a say in their life. So involving them in plan making and in making, and that is again, you know, HCBS, home and community based waiver, all of these areas, really rely on person centered planning. And person centered planning is very clear that the individual is involved in their plan and that they have a say in making decisions about their lives. Um, Accessibility, easily accessible services. This is becoming more and more of a challenge. I know it's a great aspirational goal that the department is setting in these areas, but with the rate and even with the increases in the rate model, it's extremely hard for service providers to expand service delivery and to move into new areas because uh, the rate of payment is such that it really doesn't reflect the cost of providing the quality service. So, I know that I talk to providers who tell me, oh, we could expand this program, but one of our biggest challenges is that we can't find qualified people who are willing to work for what we're able to pay. And and especially since California has upped the minimum wage for persons working in fast food establishments, in healthcare settings, et cetera. Somebody, might say, well, okay, $16 an hour versus 20, et cetera. I'm going to take that. So easy accessibility to services is a good goal to set, but unfortunately, it's not as obtainable as we would like, just like I say, because of some structural uh, challenges that we have. Um, Individuals can get the support they need when they need it. Again, uh, and we're going to talk a little bit about that later in one of the other slides. Um, there are structural problems with, at times, in terms of access to providers who have the services. Um, there sometimes can be other issues where you live can be a transportation issue, etc. Um, Staff interactions, and this is a really major one, and it gets back to, again, to the structural issue. Um, are the individuals we're serving having positive interactions with their staff? And high staff turnover uh, negatively impacts the quality of care. So when you have 30, 40% turnover in a year, that individual is just getting to know that staff person, and that staff person is just getting to know them when they're leaving. And there isn't that rapport, there isn't respect. And if you're talking about, especially in the area, if that staff person is assisting that individual with self-care and potentially intimate self-care, bathing, toileting, etc., um, that high turnover, it can be quite disconcerting for the individual who would like some dignity and privacy and respect in their daily functioning. Um, and there is some research that shows that stability and consistency in staffing is important. The national core indicators, which California and Kern Regional Center are participants in, uh, did a report in 2021-22, Human Services, HSSR, HSRI is the abbreviation for the company, which really looked at the whole area of staff interaction and the importance that has on positive outcomes and satisfaction by the individual. Um, um, yeah, the department's talking about equity in services for individual, and equity um, applies to a couple of different areas. Some of them, the DDS only has limited control over, and some of it, through the regional centers and so through some of the production of data that's coming out and the regional centers' utilization of that data is making a big difference. Yesterday's Disability Scoop, which is a publication that I subscribe to and gets articles throughout the country, had an article about how Central Valley Regional Center, our neighbor to the north, has developed a mobile service center that goes out to a number of smaller, rural, predominantly agricultural communities uh, for trying to do outreach for monolingual Spanish families and others to try to make sure that there is that equity in service. Depending on the statistics that you use, whether you look at the whole of the agency or you look at by age or by disability, you see some very different numbers in terms of what, say, for example, Anglos receive from the system versus what persons of color, Hispanics being the largest group served. And the last week at the presentation that I did, I showed how for adults 18 and older, the disparity and how that's gotten larger. But part of that has to do with the fact that there's a much the number of individuals who are Hispanic have in the 18 to 60-year-old range has increased. And as that increase has occurred, some of the service disparities have showed up, especially in the area of residential services, which is not a service that historically has been utilized to the same extent among Hispanics and Anglos, and that can account for some of that. But one of the areas that we really need to be looking at as we look at the whole area of health disparities is significant health disparities, and that's a big one. There's a lot of research out there, and down at the bottom there's addressing intellectual and developmental disabilities as a health equity imperative. The American Public Health Association in June of this year just came out with a document specific to uh,
Jeff, I think you're having some connection issues.
the system is saying poor network connection.
Just shut off your video real quick.
Okay, well, sorry about that. Yeah, I did. Higher rates of crime.
Still shows your video on. I see that you've shut your video off, but you've lost your mic. Try reconnecting your microphone. I guess we'll give Jeff a moment here as he reconnects.
Okay, sorry, we're back.
Okay.
Okay, sorry about that. It just my son's doing some stuff to get the connection back up to where it needs to be. Anyway, so inclusive planning, service plans should be designed with input from the individual. Again, the whole IPP needs to be person-centered, improving access to healthcare, education, social recreation, and employment opportunities. So, we have an entitlement, but again, sometimes the service isn't necessarily available. The healthcare clinics that are available to that individual may not be in the area that they live. Transportation might be an issue. There may be a extended amount of time that you have to wait to get in to see, especially if you're wanting to see a specialist. Employment opportunities. I know that some of the agencies that I've talked to out there saying, well, in terms of competitive integrated employment or the internship programs, we have challenges with that because we don't have enough staff to uh, take on all the referrals that we're receiving for people who would like this particular service. So we need to be looking at planning to meet the needs of individuals. Community integration, developing community integration and social well-being. And that was, when we were doing the assessments on home and community-based waiver services, and we went out to look at what the homes and day services were doing. Many of them shared, oh yeah, no, we understand this. We know we need to get out in the community, and we do that. Well, getting out into the community and building communities are not the same thing. That what we really want to do is try to get people to be involved with um, individuals who are non-disabled and have regular interactions, and to be part of organizations, to be part of recreational opportunities, to be part of an adult education, something where they are a religious group, something where they're involved with a community that's out there, and they then become part of that community. Not that we go out into the community. I mean, if I'm going to shopping and going to Target, I don't say to my wife, "Oh, I'm going out into the community now." It's just awkward, I think. Um, the We want to make inclusive situations again that the person is included. The old adage of all the adults that someone interacts with during the day who are not other individuals served by the system are people that they're paid to be with them. We want people to be in situations where they live, work, and participate with non-disabled individuals. And some of this is coming from, like I say, the American Public Health Association's report in June of this year. Um, Timely access is another area. There are, especially when you get into the need for specialized services. Basic services are a little easier. We've developed a good foundation of providers of residential services, of day services, of employment services. But that's again the foundation. We now need to build up further on those services to deal with more specialized needs, more individualized needs of the persons that we serve. And there are a shortage of specialized services and providers trained to support our individuals. So, and that can lead to long waiting lists and delays in receiving necessary care. Um, you go to a your healthcare provider and get a referral to see a specialist, and even if you're typical and are and have insurance, in many cases the wait can be 2 and 3 months to see a specialist. For our clients, it could be double that, could be much longer because there are fewer specialists out there that can meet those needs. So if somebody has, say, gastro needs or, you know, just a number of other mental health needs, other challenges, getting into specialists who have the skills to work specifically with our clientele are somewhat limited. And so many of the individuals we serve here locally will end up going to one of the comprehensive, clinics like Clinica Sierra Vista or Omni because they do have the full array of service providers. But that full array, like you said, in many cases takes a extended period of time to get into. And is that individual that they're seeing, they know that particular area of medicine, but do they have a subspecialty in working with the individuals that we're serving? Um, the primary source of funding for services in California, especially for healthcare, is Medi-Cal. And there are a lot of specialized providers who do not take Medi-Cal. So the number of individuals who will see our folks are limited. In addition, as I mentioned on Friday of last week, we're about ready to, at the national level, have a change in administration. And in 2017, there was, under the first time our incoming president was there, he proposed making some fairly drastic changes to the Medicaid system, which funds Medicare. It didn't pass by like 3 votes in the Senate, but if it had it passed last time around, we would have seen some major reductions in terms of funding for some of the Medicaid related services. I don't have a crystal ball. I don't know what will be done this time around, and I think we need to stay tuned and see and be ready to advocate if there are changes that we believe will not be in the best interest of the individuals that we serve. But like I say, time will tell. The need for services often go beyond the available specialists, causing limited access and long wait times. So we need to really try to work with finding people. That was one of the impetuses a number of years ago when I was working at Kern Regional Center for developing the telepsychiatry services that we have today, the telemedicine services, is that there weren't a whole lot of individuals who could specifically address the mental health challenges that our clients had, that the behavioral services through Kern County Behavioral Health were somewhat limited, and they didn't have individuals with the subspecialties necessary to meet the needs of individuals that we serve. Now, coordination of care is really an important aspect that we really want to focus on as we are moving forward. And that's requiring a coordination among multi-service providers, including healthcare, education, and social services. That a lot of times, and especially in the past, well, healthcare did its thing, you know, regional center would do its thing, so the provider would do their thing, and we didn't really sort of bring it all together. Some states are looking at a like an office of long-term care or some other name like that, where they are integrating healthcare and case management together to try to get a more holistic approach to the services that people receive. Service delivery and capacity is another challenging area. Integrated service models. Services focus on integrating various types of care, including medical, behavior, and long-term services. Again, instead of looking at each one separately, how does it impact? So if somebody has significant medical challenges, how does that affect their ability to be out in a community setting? How does that affect their ability in employment? Other things, if they have challenging behaviors, how does that impact their ability to see medical care or to be involved in programming? So we want to look at how do we look at all of these things as they interact with one another. As an example, I recently was talking to someone who said that, well, our one of our people was seeing the same primary care physician for a number of years, and it was working very well. And one day, the physician reached out to do the exam, and the client bit the healthcare provider pretty good bite, and that really changed the relationship. The provider said, "Hey, this individual is going to need to have some sort of behavioral intervention or some other intervention if she wants to come back to see me again." And so here's a long-term relationship with a healthcare provider who had a pretty good understanding of this individual's healthcare needs, now saying this is not going to work unless this other area gets addressed. So we need to look at how those things, again, the whole person approach to serving and supporting and addressing all aspects of the person's needs, not just focusing on, well, you do this part of it, you do this part of it, you do this part of it. That as providers who are under the home and community-based waiver, we have a responsibility of looking at the whole person and seeing how these other areas potentially impact both the services we provide and how the services we provide impact the other areas. So it's not in isolation, one service, another service, another service. We really need to be looking at how service delivery is combined and integrated. Again, we get back to where it's all about, where it starts, and that's person-centered planning. Services address the individual's specific needs and wants, promoting greater personal independence and quality of life, reflecting aims and gifts of the person. So we want to make sure that we're, again, the whole idea of looking at positive things about the individual and gifts and strengths that of that individual, and capacity building. One of the things that I know Department of Developmental Services is doing, Kern Regional Center is attempting to do through these trainings, although not whole lot of people today, and that is providing training programs so that providers of services can build their capacity, get a better understanding, better resource allocation, looking at where we're providing services. I know the community services department at Regional Center is looking at, wait a minute, where do we need to focus on developing new services? And of those existing services, what should we be attempting to do to create more and different varying types of service provision? And finally, improving funding. I mean, the rate model was an attempt to bring funding uh, up to a higher level. The challenge is going to be, and a bill just passed this last July that requires the legislature every 2 years to assess if the rates that are out there are adequate. Problem is, that's all it does is it assesses. And so the legislature might come back and say, okay, based off the study that you submitted to us, the rates are not adequate, but we don't have the funding available to up that. So the bill that got passed, assures that we're looking at what rates need to be. It doesn't necessarily guarantee that those rates then come forward. And I think that was unfortunate, but I think it's in the current budgetary situations, something I can clearly understand as to why they did that. The capacity building, so as we said, service providers having skills and abilities to provide high quality care. So one of the focuses that we really want to try to do over the next few years, especially, is as we're fully integrating these concepts, making sure that the people who are providing the services are, understand the new look, understand the what's going on, and are really moving forward. I understand that the Kern Regional Center has brought Tom Pomerantz back out and has had him go out to some facilities and look at specifically what the provider is doing in terms of assuring that the HCBS requirements are being met. And that's a really good way of making sure that the providers get the skills and abilities to provide quality of care. So it's kind of like a one more level of working with individuals. And then finally, the oversight and transparency. If we say we're doing it, are we doing it? And how can we measure what's being done? So measurement based on goals and objectives help track effectiveness of service provision to individuals. The Lanterman Act, the Welfare Institutions Code, under the section that deals with IPP, has said since it's about, I think, 1978 or something, and for much of the time, that no services shall continue unless progress is being made towards meeting objectives. Well, I don't know that anybody's ever really enforced that. And I think we need to start looking really at that. Okay, so these are the objectives that have been committed to by this service for this individual over the next year. This is our annual plan, and these are what we're going to be doing. And so how are we going to measure where you're at? And I think that's one of the things that 10% is going to do. It's going to create the measurements that will be looked at to decide whether that person has moved forward with their goals and objectives that they have set for themselves as to what they would like to see in conjunction with the providers of that service, their families, the other people significant into their lives. engaging individuals and their families to make sure that service and support needs are their preference. So we really need to make sure that as we're developing these plans, which we're then going to be monitoring, that the individual and other significant people in their life help make the plan that we're going to be moving forward with. And then as a provider, they need to have regular service plan reports on key outcomes, accessing the services supports. One of the things that I know Tom Pomerantz has said, and I've seen some providers have moved in this direction, and that is, automating case record. And there are a number of programs out there that can do this, and then you can really see, because when you're doing stuff on the record, it will track, and you can then do quarterly reports and look at where that person is in terms of now versus where they were 3 months ago, 6 months ago, and really have the data that will support the fact that we're what we're doing, and that should be, like I say, there should be oversight. There should be look behind, so that when uh, regional center is going out and the facility liaison is doing, you know, looking at what's going on, when the service coordinator is going out and looking what's going on, the information is right there. It's easy to access if you need to audit or you know, look at the productivity. It's it's there and it's transparent. It's all available. And okay, that is the extent of my slides today. And although I said I would do it in about 20 to 30 minutes, it's been 45 minutes. So it's almost like a regular full session. Uh, Valerie or Leslie, you have any questions or concerns or comments on this?
Thank you, Jeff. If I may add, yeah, so the quality incentive program is really great. It identifies, like, as part of the rate reform, that these are some areas that they want to help our providers meet, building on like the areas you mentioned, like consumer experience, equity, the quality of outcomes, as well as system efficiencies. So they're really trying to improve all of our systems with providing these incentive payments to boost your guys' services. So it's really great. And so um, hope that our vendors take advantage to get that extra 10% of that rate reform by doing some of these areas and programs that they're including. So like in the past, we've had like the wellness test where they hope that our RCFEs take our individuals to complete their annual wellness exams to get that extra incentive. Right now, they have for this month that our providers sign up for the provider directory, where our providers sign up and identify their service is available for individuals. So that way, individuals that want to have the autonomy to select their services independent from the regional center identifying those services, that they have that opportunity. So I really hope that our providers look at their emails. We've been sending it out this last week for our providers to sign up for that provider directory to get that extra eligible incentive. Okay.
Yeah,
Thank you, Jeff.
what I saw when I was going out and doing some of the HCBS assessments is that two things. One is that most providers, although they maybe grumbled a little bit and had some questions about some of the specific rules, were amenable. It wasn't like somebody said, "No, this is, I don't want to do this. I'm not going to, and especially with that sort of carrot and a stick with, hey, wait a minute, this is having to do with your funding. You know, part of this is, wait a minute, if you're going to be in this field and want to continue with it, you need to take part in continuous quality improvement. That over time, the quality of your services has to continue to improve. As I said earlier, the 10 rules for HCBS are basically the floor. These are the start. And now we're going to move to moving on. And structurally, we know we have some challenges. We know that rates aren't where they ultimately should probably be. We know we have problems with some staffing concerns. The available of a full array of services, like I said, some of the stuff I noted about like healthcare. So what are we doing to address those? And how are we moving forward through the planning process for that individual to meet that whole person as needs consistent with the HCBS rules and what is best practice and what is basically it takes to give that person a individual a independent and satisfied life.
Just wanted to mention that, I mean, it's a great that they're providing incentives because I've gone to, several different places where we've been in home to do presentations. And that's the biggest thing that a lot of the, house managers or so forth that have been there forever have talked about, that they're ready to do it, but just doing it took a little bit of that push. So them having these incentives like really helps. Okay, let's get out, let's do outings, let's get out in the community. And I've heard of a few people have said that they were still stuck in that same way of doing things, and just kind of having everything not necessarily just also push, but having incentives like so, and inquiring if they utilized all of them, and they have. So I feel like it's a great and positive thing to have this.
Okay, then. Anything else? So what we'll do, Leslie, is we'll put this on our website. And
Let's
what
go
I
ahead
was
and
doing,
stop the recording real quick.